And thank you all for Zooming in to join this breakout session. It's my true privilege to give this sort of talk to this group of patients and family members. It's really one of the highlights of my year, honestly, because this group is so engaged and so proactive about their own healthcare and that of their family members. It's refreshing to me. So today I'm going to talk about kidney transplantation. There will be plenty of time for questions and answers at the end, I think. I'm a transplant surgeon, so I'm not probably the best person to ask about what foods to be eating or, when to start dialysis, that sort of thing. But I can give those things a stab, but I'm not expert in those areas. But today's talk is really meant to give you guys a sense of how to get ready for a kidney transplant, what the transplant entails, and what sort of to expect. I know there's some sessions, maybe one going on right now about living with a transplant and how to manage that after, but today's really about getting going and how to prepare for a transplant. So we'll get started with the slides. I have no disclosures of any sort of relevance to this talk. And then this is the activity disclaimer from the foundation that you'll probably see with most of the talks. But so first we need to think about when we should start preparing for a kidney transplant. And I think a good rule of thumb, and it might vary per individual, but it's probably when your GFR, and those of you who go to clinic and have your creatinine measured by a nephrologist will know, and this is just a calculation based on the creatinine and a few other factors. Probably when it's around 30 is the time to start thinking about a transplant. Doesn't mean you're going to need one next week or next year even, or even in a few years, but it's a good time to start thinking about it and at least starting to wrap your head around what can be a really, really big thing to wrap your head around. It's a big deal. You can't be listed until your GFR, and that's either calculated or measured, is 20 or less. So if it's 21 or 2, and that's the lowest number you have, you technically cannot be listed for a transplant. One misconception, I think, that we see, not so much with this group, but with some other patient groups, is that you don't have to be on dialysis before being listed or before receiving a transplant. And we do think in general, it's best to receive a preemptive kidney transplant or a kidney transplant before you start dialysis. I know Dr. Clifford Miles from University of Nebraska is giving a session on that tomorrow that may be worth listening to. Cliff's a very good nephrologist out there, another Midwesterner, but does a really nice job with PKD folks. And it's really for several reasons, but you avoid the dialysis if you can. That's no fun for sure, the dialysis, whether you're doing peritoneal or hemo. And we do know that if you're on dialysis for much longer than a year, each additional year that you're on dialysis before a transplant means your predicted survival after a transplant is going to be less. So if possible, it's best to receive a transplant before starting dialysis. Now, that doesn't happen in the majority of cases. If you look at all the transplants in the country, only about 30% are done in a preemptive manner, if that, probably even less now. So in order to have a transplant, you need to go through what we call a transplant evaluation, and what most centers would call that, I think. And just as an aside, some of what I talk about will be very generic and should apply to most transplant centers. I will try to refrain as best I can from very specific things related to our center, and because everybody's not able to come to where we are, and there are 250 odd kidney transplant centers in the country. So, but in general, the process is fairly much the same. That evaluation, depending on where you go, depending on how much they group together, can be anywhere from 2 to 3 days at that center, or some space it out more. Certainly, if you live across the street from the center, there's no reason not to space it out. And the evaluation means meeting with a nephrologist, you'll meet with a transplant coordinator, you'll meet with a social worker, you meet with a surgeon, and that's sort of the basics. You'll meet with a pharmacist too, and then also some transplant financial people to go over your insurance and your costs or potential out-of-pocket costs. And of course, there are other tests needed. Some patients need to see cardiologists because of heart issues. Some need to see psychiatrists because of mental health issues, for example. But it's pretty comprehensive and sort of, I call it a 100,000-mile checkup because it's very thorough, and sometimes you find some things. The medical side of things really focuses on, will you benefit from a transplant? And that essentially means, do we anticipate you're going to live for a while after receiving a transplant? And for patients with PKD, that's generally fairly true. Many of you and your family members you need a kidney transplant because your kidneys are sick, not because you're sick all over and that's affected the kidneys, if that makes sense. The heart is something we focus a lot on. And again, really severe cardiac disease is not terribly common in people with PKD, but can happen, especially in smokers or those with other conditions. But really, it's uncommon to have a condition that really would say you're too sick for a transplant in PKD population. But what we do occasionally identify things that will say, we need to fix this or try to get it as optimized as we can before we proceed with the transplant. Specific things we often look at for patients with PKD are aneurysms, or enlarged blood vessels in the head, inside the arteries that supply the brain. That tends to run in families within PKD kindreds or families. And then that's usually screened for with an MRI of the head. And occasionally we identify those that need to be dealt with before a transplant to prevent strokes. Many patients with PKD, or almost all really, will have some number of liver cysts. The question is how big they are and if they're really symptomatic. Rarely we'll refer patients, or they will have come to us through our liver transplant clinic for cystic liver disease. And we'll talk about this a bit more later, is the need for what we call native nephrectomy, or having your own kidneys removed at the time of or in preparation for a transplant. The surgery evaluation, usually this is one of your shorter visits at the clinic, but it focuses on any prior transplants you might have had, prior operations on your native kidneys. And then we really examine the abdomen fairly closely, taking a good inventory of the size of your kidneys, any prior transplant incisions or other operations. And then we feel your pulses down in your groins. Those are the arteries that we use to sew the new kidney into up a little higher. But if they feel good down in the groins and they're nice and strong, then generally that's an indication they'll be good upstream. The psychosocial evaluation, and this is generally conducted at each center by a social worker. And we're really looking for severe things that might preclude dealing well with a transplant or dealing well with the regimen of medications and that sort of thing afterwards. People with, schizophrenia, severe mental illnesses, sometimes we have to turn down, but not very commonly. We like people to not have significant dependence on chemicals, especially illicit drugs and/or alcohol. The social workers will talk to you about what kind of support you have and how you'll be able to pay for some of the out-of-pocket costs. People with good insurance, generally, they're not a tremendous amount of out-of-pocket costs, but there are some, whether it's just traveling to your transplant center or whether it's or paying for some of the co-pays of the medications. But the social workers are fantastic about working with you on that. Very common for folks to come to have the evaluation and then they're really raring to go and then get listed or proceed with a living donor transplant. These are the sorts of things that might delay things or prevent ultimate approval for a transplant. Cancer is a very broad term, but people with active or very recently diagnosed and treated cancers of certain types. We tend to have a waiting period for before we do a transplant, and other things that, and this isn't very common in our PKD populations, but people with a chronic illness, say maybe bad emphysema or something like that, or really bad heart disease that would really predict you're likely to die within the next few years. It's probably not the best thing to go forward with a transplant. As we mentioned, poorly controlled mental illness is an issue sometimes, but not very commonly. Severe obesity, and each center you'll visit with will have sort of their own criteria for what they consider to be too obese, perhaps to list for a transplant or to approve for a transplant. That will vary across the country at different places. Most places will have a body mass index cutoff of somewhere around 35 for that body mass index, and ours happens to be 40, but it depends on the center. And we recognize body mass index is not a perfect way to estimate obesity. The ideal way would be to put everybody in a water tank and measure their percent body fat, but it's one way that we can easily calculate things, but it can misrepresent some people's body fat and muscle distribution. Rarely we see folks that can't remember to take their medicines, but that doesn't mean people with fairly significant mental challenges can't receive a transplant if they have good caregivers. As I mentioned, current drug or alcohol abuse, and then occasionally, and again, this isn't very common in our PKD population and the folks we were able to see, but people that just really don't comply very well with medical treatments and or their dialysis. They skip dialysis quite a bit, and just perhaps won't, because getting a transplant's not a cure, and it's trading one condition for another, but you need to be able to participate in the with your team and follow the recommendations. How do you best prepare for a transplant? I think it's like preparing for any sort of surgery. And I think you really, the long and short, you want to be in as good a shape as you can going into it. Excuse me. Increasing your physical activity is good to help you prepare for the anesthesia. People that are fit and a little more active going into any type of surgery tend to recover a little better. The next few, the low sodium diet and the saturated fats are more just your good general advice to any of us, especially those with kidney disease. Ideally, people are able to abstain or stop using tobacco, and that generally, there are negative effects of both vaping and smokeless tobacco, cigarette smoking and tobacco, and cigars are probably worse from the effects they cause on the lungs, but there are there can be bad cardiovascular effects with tobacco use in general. And then if you find yourself in a category that you think you might want to lose some weight, we would recommend that. And that's one, to minimize your chances of any incisional or surgical related complications at the time of the transplant, and really long-term, 10, 20 years down the road, to improve your overall health and minimize the chances of developing things like diabetes after the transplant, or significant heart disease or cardiovascular disease. And this is, I'm not, again, a dietitian, but a good way to lose a pound or two a week, which is probably what many folks consider to be medically safe and not too drastic, would be to eat around 1,500 calories a day for most men. And this is fairly general, but depending on your size, it can vary, and about 1,200 calories for women, in order to lose about a pound or two a week. And so that can be helpful going into things. And again, these are the reasons to improve your condition or prepare for things. And that's why it's nice to start when it's around 30 or so, because you have some time. Rather, it's not going to be an emergency. So we do recommend you get in as good a shape as you can, knowing that that's not always possible, because sometimes you feel miserable. Generally, there are two types of donors for kidney transplants. The one is a living donor kidney, and that can be a relative, it can be a friend, it can be a church member, it can be an acquaintance, it can be somebody that in your community that from church or from work that decides they're interested in donating a kidney to you after they hear your story. And then there are deceased donors, and these used to be called cadaver donors, but now the term is deceased. And those are from donors that are either brain dead due to some catastrophic neurologic insult, whether that's a trauma in a car accident, or whether it's something like a stroke or a drug overdose. And then there's what we call donation after cardiac death, where the patient isn't able to be declared brain dead, but they've suffered what is deemed to be sort of an unsurvivable injury, and their outcome is such that their prognosis is quite poor. And in that case, their support is withdrawn, and then the organs are harvested in a relatively quick fashion in an operating room. If possible, we are really big fans of living donation, and the reasons are really three, if not four. And we recognize also that everybody doesn't have a potential living donor, especially in some PKD families. The patient or the members of the family that aren't affected by the genetic mutation many times have donated to another family member, and so that kind of narrows the donor pool, at least within the family. But if you can and are able to find a living donor, we can oftentimes do the transplant before you need dialysis. The waiting time, I say no wait, it doesn't mean you're approved and the donor's approved and then you do the transplant the next week. You may not need it the next week, but the waiting time will depend on where you live in the country, or more specifically where you're listed for a transplant in the country. Here in the Midwest, if your blood type is O, average waiting times are about 5 to 6 years. And that's just one example. B is a little bit longer, A is a little bit shorter. If you're on either coast where there are many, many people waiting, these waiting times can be 10 to 12, 13 years. So quite a long time. In general, living donor kidneys tend to function immediately, meaning they start making urine right after we sew them in. You don't need to do any dialysis or experience what we call delayed graft function, which happens in about a third of deceased donor kidneys. It doesn't mean they won't work. It just means that you might need to do some dialysis while the kidney's recovering in a deceased donor situation. And then in general, living donor kidneys tend to fare better long-term. And that's mostly because we know a lot more about the living donors, I think. It's not, I mean, if everyone received a kidney from an 18-year-old deceased donor or a 25-year-old or some very young, healthy donor that we knew a lot about, there probably wouldn't be a difference. But I think, we do such detailed testing in the living donors that that probably accounts for most of the difference in these survival curves. And they're not too far apart early on. And the way we define graft survival or survival of kidney is that you have not returned to dialysis or started dialysis, or you haven't had another transplant. But if we look at 10 years, 63% of the living donor kidneys are still functioning, and these are national data. And then compared to deceased donors, and that's around 1 in 2. So a difference, and it gets a little larger as you go farther out. This is sort of why the waiting times are quite long. When I finished putting these slides together a month ago, there were about 90,000 people in the United States waiting on a kidney. Last year was the biggest year of deceased donor kidney transplantation ever, and there were 18,699 done. So that's 70,000 short. And that was the biggest year ever for deceased donor kidney transplant. There were just under 6,000 living donor transplants done. Just as a matter of perspective, polycystic kidney disease patients account for about 6% of those patients on the waiting list. Then that's more it doesn't mean you have any more or less priority in the waiting list. I just think it's nice to kind of know what proportion of folks in the country have it. Again, these are our waiting times. I mentioned 5 to 6 years for O, 4 to 5 for A, 6 to 7 for B. AB wait less, but it's not real short still. It's still 2 to 3 years. So it's can be a really long time, much of which might be spent on dialysis. One question that we encounter a lot in clinic when we talk about deceased donor kidney transplantation is, should I be listed at multiple places, meaning multiple transplant centers? It's a very good question, and it's a complicated answer, and it keeps changing. So, but as of last year, the way kidney, and hopefully you can see me outline, this is where we work. This is called Region 7. And so that includes Minnesota, North Dakota, South Dakota, Wisconsin, and Illinois. What used to happen is that if a kidney were here in Fargo, North Dakota, which is about there, that kidney would first go to people in our little 3-state area. If no center accepted it there, then it would go to the region, and then it would go out nationally. And what UNOS did, after considering a lot of different models, is they removed that sort of local boundary based on map lines and things. And with many other organs did this too. In fact, all the other organs did this, and it's based on sort of the distance between where the candidate, meaning the kidney transplant candidate, is listed for a transplant, and so that transplant center, and where the donor hospital is. And this is just an example right out in the middle of the country. And the number that we use for kidneys is 250 nautical miles. Why they chose nautical miles, I don't know, but they're not exactly the same as normal miles. It's about 1.3 normal miles. But as an example, and so if you're listed at the center where the donor is, for example, and this graph depicts that, you'll get 2 extra points. So if that donor is at our hospital and you're listed at our center, you get 2 extra points. And then it sort of goes down. If you're 250 miles from where that donor, if your center is 250 miles from where that donor hospital is, you get 1/250th of a point. And a point roughly is equal to excuse me, to a year of waiting time. Then if nobody within that 250 nautical miles is interested in the kidney for their patients, it goes out to the national list. And then there's a bit of proximity there too. At 250, you get some, but it goes down over the miles. What that means is where your center is. And the short answer is, I think it can be beneficial to be listed at more than one center, especially if their sort of circle, if you will, of 250 miles from within it is, encompasses some decent sized metropolitan areas. This is one example of a center in Minnesota. Their circle extends way up into Canada even, but we don't usually get organs from Canada. A lot of North Dakota and South Dakota. There's another center in Minnesota that's about 75 miles south of this one, and that's represented by this red dot. And that center circle ends up getting down into Milwaukee and Chicago quite a bit. And so there is potentially some advantage to being listed at more than one center. It's complicated. It used to be that you wouldn't want to be listed at center A and center B 75 miles away. There wouldn't be any advantage, but there might be advantages in certain circumstances where you would want to be, even though they don't seem that far away as the crow flies. Living donors briefly. One thing that's often asked is, how do I find a donor? Well, that's a great question, but donors, we're not allowed to find donors for our recipients. That's frowned upon by UNOS and by the Center for Medicare and Medicaid Services. So generally the donor will contact us after they've expressed a wish to donate. And then we have them undergo a very comprehensive evaluation, similar in a lot of ways to the recipient evaluation. Some tests are exactly the same and some tests are a little bit different. And then we would decide if we think they're an appropriate candidate to donate. And then it's up to them whether or not they ultimately go on to donate. Generally, you have to be in decent health, and nobody's probably in perfect health, but in generally good health. There are some centers that will accept donors with mild high blood pressure or hypertension. And by mild, meaning it's very well controlled on like one medication and not a huge dose of that medication. You may have read historically, for the most part, about blood group incompatible transplants or transplants with a positive cross match at certain centers. That's not done very much anymore. And that's because of this concept of kidney pair donation. And the simplest way to explain kidney pair donation is if you have a recipient on the right-hand side here, number one, who is blood group A, and then their potential donor is blood group B. That typically doesn't work very well. And then you have another pair where the potential recipient is blood group B and the potential donor is blood group A, which also doesn't work very well generally. You have the donor donate to the compatible recipient. And even though they're not related to that person or even came to the center, the transplant center with that person. But this has really helped increase transplantation for a lot of people. Even the number of centers that were doing these transplants across blood group barriers or barriers across the tissue type antibody barriers, that was a pretty small number of centers, whereas this sort of thing can apply at any center. And many, many centers in the United States participate in this. And these chains mathematically can get quite long. You read in the newspaper about chains of 16 kidney transplants, that sort of thing, separated by days or weeks, and then certainly separated geographically. And so the kidneys tend to fly around a lot. And generally it works very well. So this has been a very nice innovation in kidney transplant and may expand to liver transplant in the not too distant future for living donor livers. How do you find a living donor? I don't have the exact answer for this because I've never had to look for a living donor. And I imagine it is a very, very nerve-wracking and hard thing to do. People handle it differently, I think. And some people are very vocal about their story and what they need. Some are very private and don't want others to know about their health conditions. And that's an individual decision and preference, and that should be respected. But I think the long and short of it is you don't really ask anybody for a kidney, or most of our candidates don't. I think the more people that hear your story, the more people that are likely to volunteer. And many would, even if you keep saying no, they're going to say, I really want to do this. And it's a huge deal. And it's one of the greatest things people will ever do in their lives, I think. But I would imagine it's very, very nerve-wracking to go through this, but I've not lived through it. So I don't have the exact answer. But in general, the more people that know, billboards used to be the thing. Now there are other avenues, Instagram, Facebook, other websites that people create and propagate their story. And the more people that know your story, I think the better. So that's the long and short. If you're uncomfortable about telling your own story, I think family members or recruiters, if you will, or champions, they're really good at getting your story out there. They can, as long as you let them, they will be very good about advertising your story if you're comfortable with that. Social media is a good tool, I think. Sometimes it will overwhelm the living donor coordinators because they'll get 200 inquiries from about a certain individual, but that's pretty uncommon. So I would still favor using it. The transplant itself, in the next few minutes, we don't always remove your own kidneys. These are your old polycystic kidneys up higher. We work from the front. We make incisions lower down in the abdomen. And so the kidneys into the blood vessels that go to the leg. This is what a freshly transplanted kidney looks like in the operating room. They all pretty much look the same. And this is what a normal kidney looks like. This is obviously not a polycystic kidney. Surgery of any type has risks. There are infections that can happen. Transplant patients are a little more at risk for certain types of infection. And most of these are any, complications related to any surgery and being in the hospital, things that aren't, if you had your colon removed, things that don't apply to that are things like rejection of the new organ, and then just delayed kidney function or delayed graft function. We talked about needing some dialysis after. There can be leakage of urine or other issues with fluid after the transplant, but most of those can be dealt with in the time you're spending near your transplant center recovering. Very, very common issue for patients with PKD is what to do about my old kidneys. General rule of thumb, if they're not bothering you, many times we just leave them alone. But there are reasons we will remove them, or the patients would like them removed. And that's oftentimes pain. And by that, I don't mean the occasional twinge, but I mean people with life limiting or severely severe pain. Some people even are on narcotics. Then, really being full and with really large kidneys and not being able to eat very well. There are patients, as you may know, with recurring infections of the cysts or bleeding from the cysts. Rarely there's a case where there's not enough room for the new kidney or a dissection to put in the new kidney. That's pretty uncommon, but can happen. And then occasionally there's a suspicious cyst, or more commonly a mass on a polycystic kidney. That can be very hard to tell, that we might be worried might be a cancer, and then they should be removed. This is a CAT scan of a patient with polycystic kidney and a little bit of liver cystic disease as well. The old kidneys are highlighted and surrounded by yellow, and then the new kidney is in green, outlined there lower down in the pelvis. These are not massive PKD kidneys by any means. This is a different example of a patient prior to transplant, and these kidneys were really quite big. And so these actually were probably in the category where they needed to come out before a new one went in. Depends where you go, how that center will address your kidneys. Our current approach, at least here in Rochester and at Mayo Clinic, Arizona, is to remove them at the time of the transplant. And so you have one operation. It's a longer operation, and it takes a little longer to recover from, but usually just one. And then you get the transplant after those kidneys are out. But some centers prefer to remove them afterwards. That used to be our approach. We would remove them at 3 to 4 months after a transplant. Some are pretty dead set on removing them before. There's no right answer. It's more just practice preference. But at least the way we're doing it, we think has worked out nicely, because patients just have one surgery. But certainly, even if you have a transplant tomorrow and your kidneys are not bothering you now, a year or two down the road, or 5 years, they can be removed if symptoms do develop. This is an example of one of my partners, Dr. Mikel Prieto, who had really been a pioneer in removing these very large kidneys. And this is an example of one of the kidneys he removed. And this is done through a minimally invasive technique where you have about a 7 or 8 centimeter incision, and then laparoscopic instruments are used. So it's pretty slick the way he does it. And this is the same way we would do it at the time of the transplant. So in summary, and then we'll have time for some questions. And I see quite a few coming through on the chat, and we'll get to those in just a second. I do think it's important to go to a center that has, and there are quite a few across the country that have experience with transplants, and certainly with PKD as well. We'd recommend you're in as good a shape as you can be before and after the transplant. Ideally, you're able to find a living donor, but it's not anybody's fault if you don't. It's a complicated process, and it's many people are able to find quite a few people that are interested, but they're just not a candidate for some reason. That doesn't mean they can't help in other ways, be a caregiver. So it's nobody's fault if you don't have a living donor. But and this is a bit like preaching to the choir with this group, but I think the best patient is an informed patient and one that can advocate for themselves. So that's what I have. My contact information is here. It's probably in the profile on the PKD site as well, but certainly feel free to to call or reach out by email anytime you like. We're happy to answer questions. This is put in by our PKD colleagues at the foundation, and this is just to remind you that there is a registry. Occasionally, people that have their native kidneys taken out, these kidneys can be sent to research facilities that use those kidneys, for example. And this is, but that doesn't mean you can be in the registry without that. This is just sort of to see how people do with PKD and after a transplant. So I'll go up to the chat and I'll stop sharing my screen here, and so I can look at you, and we'll go to the chat and answer a few questions. The first, I'm just going to take them in order. The first question is essentially, is it possible to have a third transplant? And it is. The second part of that question is, how much difficult is it? From a surgery standpoint, it's not a lot more difficult. It probably adds a bit of difficulty to the surgery, but it honestly, until you end up with the fourth or fifth or that kind of numbers of transplants, it's not a lot different. Usually there's plenty of space. You just put it in a different spot on the blood vessels. I think one thing that is maybe more difficult is oftentimes folks are older by the time they end up with a third transplant. And so the way they recover may be a little different than what they remember from the first couple. But certainly, basically, yeah, third and fourth and even fifth are possible. Next question is, when the call comes with the offer of a kidney from a deceased donor, what are the questions one should ask? I think that's a good question. I think you shouldn't need to ask a lot of questions, honestly. The center's not probably going to tell you where that donor is, how old they are. It's fairly generic, and that's mostly in the interest of protecting the donor's family, because of newspapers and news and social media. It's sometimes not as hard as you think to put things together, who it might have been. So the main thing is to keep the anonymity of the donor. I think hopefully you're going to be listed at a center that they wouldn't call you unless they thought the kidney was appropriate. And I can't say that's the case everywhere, but I think that's an important thing. We typically won't call you unless we think the kidney's appropriate. And it's, I don't know that it's, that someone who hasn't, been trained in the area, it would be fair to ask them if they think they want this kidney. So we generally would not, or at least our practice, we wouldn't call you unless we thought it was an appropriate organ for you. Is the kidney transplant surgery more specialized or different for PKD patients compared to other medical reasons for kidney failure? The surgery itself generally is not much different. It's probably in some ways a bit more straightforward because people with PKD don't tend to have as much cardiovascular disease. So their arteries that we're working with tend to be a little bit nicer to work with, not as much hardening of the arteries. And then, but unless we're going to take the kidneys out the same day, and that obviously adds, a few hours to the operation. But it generally will not be a lot more difficult. And then, are the transplant outcome stats the same for PKD patients and other kidney failure reasons? Probably. We don't have them specifically for PKD from a national standpoint, but my suspicion is they will be better because that graph, the failure also includes patients that died with a functioning kidney. And so that can be a big reason. And in general, patients with PKD don't have, the other comorbid conditions like severe diabetes or heart disease or that sort of thing. Again, the kidneys are sick because they have a genetic problem. They're not sick because the patient around them is sick. The next question is, are prospective transplant patients at a disadvantage who have Medi-Cal/Medicaid insurance? Typically not. I don't know Medi-Cal specifically because I've never worked in California, but Medicaid is and that generally is restricted as far as where you might be listed. That would be one difference perhaps than if you came with Blue Cross Blue Shield or a private insurance or even Medicare. Medicaid is a state-based system, and so oftentimes they only will have reciprocal relations, meaning that with states that kind of touch them, and that's not always the case. For example, Iowa Medicaid doesn't cover a kidney transplant in Minnesota, but Wisconsin Medicaid does. So that'll depend more on the state's rules about their Medicaid. But from a kidney allocation system or your eligibility for a transplant at a center that is covered by that Medicaid, I don't think you'd be disadvantaged. Is there a BMI that is too low for transplant? I don't think a BMI itself. I think if that BMI, say somebody has a BMI of 17 or something really low, I think, or 18, I think that would depend on if that's because they're just really small, which happens. There are small people, or if it's due to poor nutritional status. That might be the only time you want that improved before you would do a transplant, I think. But there's no, it's not something we encounter commonly, to be honest. The next one is, what valve issues would prevent or delay approval? I assume this is referring to heart valves, because the next is question MVP, so mitral valve prolapse. That shouldn't. It would really be significant valvular disease. Sometimes people need their aortic valve or their mitral valve replaced prior to a transplant because there's so much leakage around the valve or it's so narrow, but that can generally be dealt with. Can they deny a spouse for donation if we have young kids? Not outright, I don't think. Most centers wouldn't, but some might if they think, if the psychosocial evaluation of a donor evaluation means that they think it's too much burden. But that's, I think, a very subjective thing, and I wouldn't say that would be a common reason for denial. But I can't promise it hasn't been used. A few more questions in the last 3 or 4 minutes. Do the native kidneys ever continue to grow and cause impact to the transplant kidneys? Generally not. They, even if they grow, they're unlikely to affect the transplant kidney. But when we've studied this, they don't get a lot smaller, but they don't tend to get a lot bigger. And they rarely would cause any problem on the new kidney. How many days can pass between harvesting and transplanting of a kidney? How is perfusion maintained? So there is no perfusion. These kidneys are on ice. There are some pumps that are used, but that's just cycling a preservation solution through the kidney, not oxygenated or blood. And then generally we like to have the kidney to the recipient within a 24 hours is a good rule of thumb, but you can push that out to 36 hours, especially if you're using some of these preservation pumps, but 24 to 36 hours. Next question is, I'm a woman and I have 3 kids. A friend told me that my husband wouldn't able to donate to me because he's a man and hasn't birthed any kids. Is this true? No, that's not true. There is possible that because of we talked about these tissue type antibodies a little bit. People that have had pregnancies or prior transplants or a lot of blood transfusions can develop antibodies against certain tissue types. So, but without testing your husband's blood, I wouldn't say they can't donate directly to you. The map you showed of centers in the 250 nautical miles, where that's from the UNOS website, is that map. And you could probably search UNOS kidney allocation scheme or something like that. You should get to those maps. Then there's this. Oh, how do you find a good transplant center? That's a fantastic question. The follow-up to that is, does it matter if they have a PKD clinic? I think it does. I think or whether they have a formal PKD clinic, not sure what that is, although I saw the slides going forward. I think they should have experience with polycystic kidney disease. There may be, a nephrologist at a very small center that sees a lot of patients with PKD. It's not common. I think it's helpful if that center has experience with PKD, partly because of some of the liver issues, the brain aneurysms, that sort of thing, is important. And if you look at most outcome data in any kind of healthcare, volume does tend to relate to outcome. I'm not saying that there aren't some good smaller transplant centers in the country, but if you look at heart surgery, if you look at pancreas cancer surgery, if you look at any kind of, if you look at people, CHF, heart failure, those sorts of things, volume tends to equate with outcome. So I would pick a larger center, but that's me. And I'm happy to go a little bit longer if you guys into your stretch break, if for those of you that are interested in staying on to answer a few more questions. That was the 5-minute warning 5 minutes ago. Then there is a survey to, there's a good question. Can PKD develop in the new kidney? And the answer is generally no, because the PKD is the gene in your own kidneys or in the recipient's kidneys, and the new kidney doesn't have that gene. So typically, now occasionally a kidney will have a cyst on it, or develop a transplanted kidney will have a cyst, but not polycystic kidney disease. And then let's see, Joe's got a couple things. And then can someone with the duplicated system donate? And what if the donor has kidney stones? I assume I was going to assume that the ureter or the urine, the system that drains the urine from the kidney, is occasionally duplicated, and that can be used. Donors with that, sometimes it's both sides, sometimes it's just one side, but two ureter kidneys can be used just fine. And then the other part of that question is, what if the donor has had kidney stones? I think that totally depends. So when we see people with kidney stones, whether they have passed a stone historically, or if and generally that's documented on some sort of CAT scan is usually the way that's been done. Or if sometimes we find people with stones that they didn't know they have when we're doing the donors, when we do a CAT scan to look at their anatomy and their kidneys. Some donors with kidney stones can develop or can go on to donate, if they're not what we call active stone formers and they have a relatively small, meaning 1 or 2 stones probably only in one kidney, and we would typically remove that kidney. And they generally don't cause problems in the recipients. Rarely they can, but the way you tell if somebody's a stone former or currently a stone is you measure the level of different elements like calcium and phosphorus and other chemicals in the urine, usually with a 24-hour collection. And if there's a lot of those, it means they're more likely to form stones. What happens with the adrenal glands? The adrenal glands in the donor are not affected. They're separate from the kidney. And even though the textbook I learned anatomy from, it showed it like a hat sitting right on top of the kidney. And it's actually a little bit separate, and there's a nice plane. And so the adrenal glands will stay in the kidney donor, and the living donor keeps their adrenal glands. And when we take out big polycystic kidneys, we are usually able to preserve the adrenal glands too. Rarely one has to come out. The good news is you only need one. So it's kind of like kidneys that way. When do you think scaffold grown kidneys or humanized kidneys will be available? It's an excellent question. Related to that is sort of the pig kidneys that you might have read about. I think probably, my guess, and I'm not a researcher involved in scaffolding and growing kidneys that way. I think that's probably 15 to 20 years out, but that's a guess. I hope it's a lot faster, but I'm guessing something like that. But the complexity of these organs is such that to reproduce in a box or a dish or however you want to do it is, I hope it's faster than that, but and the pig kidneys are probably 10 to 15 years out, I would guess. Hope,
I want to jump in and just say we've got, I think, time one more question, and then we have to wrap up here. So we're going to
okay,
text and self get into the next session. But thank you
sure.
all, and thanks for
Yeah.
sticking around, Dr. Dean.
Oh, happy to. The question about the large PKD kidneys, I've not seen that, but it's probably possible on the nerves. And then the last one would be, what is the usual GFR for needing a transplant? I was told that body chemistry was more important for PKD patients than GFR. I think I think what that question gets at is that oftentimes people with polycystic disease tolerate a lower GFR than others, again, because they're typically not as sick overall. And so, I don't think there is a number, most of the people we transplant are probably 12 to 15 in general, but we have some people with PKD that ride it out at 7, 8, 9, again, because they're generally pretty healthy around it. So, well, thanks so much for those are excellent questions. You actually covered most of the things that I would answer in clinic. So that was really well